And all, we are straight away moving to the next session. We all know that our eyes are our windows to the outside world. But as ophthalmologists and clinicians, we also know that they are the windows to a world inside too. And literally speaking, we say our eyes convey our feelings, our emotions. But we know that the two tiny openings in our eyes, the pupils, they convey valid information regarding changes happening in our magnificent central nervous system too. And if we take and pick up these clues meticulously at the right time, we can come to very definite and prognosis-changing decisions. And this, my friends, is the charm of the most enigmatic subspecialty in ophthalmology, neuro-ophthalmology. Today we are trying to put across an IC in which we can have a very systematic approach in one of the most common but very confusing clinical finding in ophthalmology, that is disc edema. So I'll be starting off the session. I'll be talking about the basic clinical evaluation that you have to do in a patient with disc edema. I'll be mentioning almost all the findings, and as we proceed through the IC with the subsequent speakers, you will get to know how to streamline these findings to come to the right conclusion. I'm Dr. Deepa, Associate Professor of Ophthalmology, Government Medical College, Ernakulam. So starting with history, we should ask for headache, projectile vomiting, transient obscuration of vision, diplopia, defective vision, Uthoff's and Pulfric's phenomenon, which is usually seen associated with optic neuritis, scalp tenderness, jaw claudications, usually seen in AION, focal neurological deficits, fever, anorexia, arthralgia. Coming to the examination part, visual acuity, it can be normal or reduced. Sometimes it can be a sudden, profound visual loss which is progressing, associated with pain. The color vision may be normal or affected depending upon the cause for disc edema. The pupil can be normal. There can be a relative efferent pupillary defect or even an APD itself if it is a long-standing case. And on slit lamp examination, what we have to pointedly look for is whether there are any anterior vitreous cells. Fundus, again, we are looking for the findings in different conditions. You have to keep in mind papilledema. So in the early stages, you have to look for a blurred disc margins, hyperemic disc with absent spontaneous venous pulsations. If it is an established case, there will be dilated and tortuous veins, peripapillary patterns, lines, flame-shaped hemorrhages, hard exudates, cotton wool spots, a macular star or a fan. And in chronic cases, there will be a champagne cork appearance with obliterated cup, opticociliary shunts, and retinal pigmentary changes. And atrophic stage shows a pale grey optic disc and narrow vessels with pigmentary changes. If it is a papillitis, mainly it will be a hyperemia with blurred margins, but the edema will be less compared to the papilledema where it was 3 to 6 diameters, it will be less than 3 diopters. Fewer hard exudates, dilated tortuous vessels, few hemorrhages, and vitreous haze. Later, perivascular sheathing and obliteration of the cup may be seen. Retrobulbar neuritis may not have any finding. The fundus will be within normal limits. And in neuroretinitis, the papillitis features with hard exudates and macular fan may be seen. At AION will show a pallid disc edema with splinter hemorrhages, and in arthritic AION it will be a hyperemic disc edema, though diffuse, a segment of prominent involvement may be noted. Now, these are the basic things that we examine while doing a fundus evaluation. Other than that, there are some tests also that we have to do. The findings in each of these will be dealt with the subsequent speakers. So the tests that we have to do are HFA of fields, then fundus fluorescein angiography, neuroimaging to find out the cause, and a VEP to assess the functions of the optic nerve. Some systemic conditions that we have to keep in mind are malignant hypertension, Addison's disease, hypoparathyroidism, pregnancy-induced hypertension, and blood dyscrasias. The investigations: routine hemogram, ESR, CRP, MANDO, VDRL, ANA, toxoplasma, X-ray chest and PNS, MRI to look for space-occupying lesions or demyelinating changes, and idiopathic intracranial hypertension, VEP, CSF study, and look for NMO, anti-MOG antibodies. These are all what to go for, which to go for in which condition depends upon each case. So in the coming sessions, we'll see how to approach a case of disc edema. So with that, I invite my next speaker, Dr. Manju Abraham, Professor, Department of Ophthalmology, Government Medical College, Ernakulam, to shortlist the common causes of disc edema. Thank you.
Thank you, Dr. Deepa. Good morning, everyone. Excuse me. Dr. Manju Abraham. Okay, good morning. Now let's see some of the common causes of optic disc edema. Now when you see an optic disc swelling, it may be due to an intrinsic ocular condition, it may be an intracranial lesion, or it may be a systemic disease. Now when you examine a disc, find out whether it is a true disc swelling. Is the optic nerve function affected? Is it unilateral or bilateral? Is the disc hyperemic or pale? Now look at this. You can see the disc is elevated. It's hyperemic. The cup is full. The vessels are dilated and tortuous. The margins are all blurred. There is obscuration of vessels at the disc margin. You also see hemorrhages, exudates, and edema in the peripapillary region. And this is a true edema. Whereas here you can see the disc is elevated, the margins are irregular, but there is no obscuration of vessels as they leave the disc. You don't see any peripapillary hemorrhages, exudates, or edema, and this is a pseudoedema. Now let's see some causes of disc edema. Now if it is bilateral with normal vision, it may be an early papilledema, a grade 4 hypertensive retinopathy, or a diabetic papillopathy. And if it's associated with the decreased vision of sudden onset, it may be toxic, like in methanol poisoning. It may be an atypical papillitis, sequential involvement in AION, or inflammatory conditions. And gradual, it's a vintage papilledema, and sometimes compressive or infiltrative lesions affecting the optic nerve. Now, patient complaining of headache, tinnitus, transient obscuration of vision, visual acuity recorded is 6/6 both eyes, but the fundus shows a hyperemic disc edema with dilated vessels and few hemorrhages, exudates in the peripapillary region and in the macula. We think of an established papilledema. These patients require an urgent systemic and neurological workup. You need to do MRI brain and MRV and sometimes a lumbar puncture. You have to rule out causes like a space-occupying lesion, intracranial bleeds, meningitis, idiopathic intracranial hypertension, and venous sinus thrombosis. Now, a grade 4 hypertensive retinopathy, usually seen in young patients with uncontrolled BP. Again, it's a bilateral hyperemic disc edema. The arterioles will be very narrow. You can see streak hemorrhages and soft exudates extending well beyond the disc, and you can see hard exudates also in the macular area. So make it a point to check the BP in the OPD itself before sending the patient for a neuroimaging when you see a bilateral disc edema. Diabetic papillopathy usually presents as a mild visual loss. It may be unilateral or bilateral. You can see the disc is mildly hyperemic, and mild disc edema is seen along with features of a moderate NPDR. Sometimes you can see telangiectatic vessels also on the surface of the disc. It's considered to be a mild form of NAION and usually spontaneously improves over the coming months. Weak age syndrome also presents as a bilateral panuveitis. Here you can see that along with disc edema, you can see some multiple serous detachments of the sensory retina, and sometimes even exudative detachment may be seen. Now look for other signs like a neurosensory deafness and signs of meningism. Make it a point to look beyond the disc. No, don't just concentrate on the disc. Now coming to unilateral disc edema, again causes with normal vision, it may be an asymmetric papilledema or an early non-ischemic CRVO or a diabetic papillopathy. If associated with a decreased vision that is gradual, compressive or infiltrative lesions of the optic nerve, or it may be a Faster-Kennedy syndrome. Sudden can be painful and painless. If If painful, think of optic neuritis, a neuroretinitis, posterior scleritis, uveitis. If painless, it may be an anterior ischemic optic neuropathy, Leber's hereditary optic atrophy, ischemic CRVO or ocular hypertony, and also examine the other eye carefully to rule out any subtle disc edema or disc pallor. Now, a typical optic neuritis presents as a subacute monocular visual loss. A typical case usually is seen between 20 and 45 years. Characteristically, the patient complains of pain on ocular movements. The findings are similar to papilledema, but the disc edema is less marked as what you see in papilledema. Main causes are demyelination, others are infection and inflammation. You have to do the relevant investigation to find out the cause of optic neuritis. Now, a patient slightly older, more than 50 years, complaining of unilateral, sudden, painless, and profound loss of vision. You see that the disc, you can see a diffuse disc edema that is slightly pale and hemorrhages on the disc surface and also extending into the peripapillary region. This starts as a hyperemic disc edema, but as days evolve, it turns into pallor. You can also see there is an absence of cup, and in the other eye also that it's called a disc at risk. A clinical diagnosis is a non-arthritic AION. The systemic risk factors associated with this are hypertension, diabetes, dyslipidemia, a nocturnal drop in blood pressure, or an obstructive sleep apnea. In the young, hyperhomocystinemia is an important cause. You have to control all that to prevent involvement of the second eye. Neuroretinitis, seen in young patients, complaints of pain on ocular movements. About 10 days or 2 weeks after the onset of disc edema, hard X-rays also start appearing at the macular area. Common causes are toxoplasma toxocara or a cat scratch disease. Now, when you see these hard X-rays, we can exclude demyelinating conditions. Arthritic AION, it's in the more elderly age group, unilateral, profound loss of vision. They may complain of headache, jaw claudication, or scalp tenderness. Temporal artery is tender and pulsations are absent. You can see a pallid disc edema, and ESR and C-reactive proteins may be elevated, but a temporal artery biopsy is the diagnostic tool. So you have to treat the patient promptly because it's mostly due to a Jansel arthritis. Otherwise, the second eye also can get involved in the next few weeks. Leber's hereditary optic atrophy, usually seen in males of the younger age group between 15 and 35, complains of unilateral severe painless central visual loss that occurs in a stepladder pattern. You can see the disc is hyperemic and mildly edematous, edema spreading to the surrounding retina. Sometimes you can see telangiectatic vessels also in the peripapillary region. Mimics an optic neuritis, but here the family history is very important. It's maternally inherited. The second eye is also involved the next few weeks. The prognosis is not good. Ischemic CRVO, we are not going to misdiagnose this. You can see disc edema, veins are very much tortuous and engorged. You can see hemorrhages and soft X-rays extending up to the periphery. Now, compressions with the optic nerve may be due to optic nerve glioma or a meningioma of the optic nerve sheath. The disc is swollen, and sometimes you can see opticociliary shunt vessels also. Rarely you can see such a picture due to infiltrations to the optic nerve due to lymphoma, leukemias, or tuberous sclerosis. Posterior scleritis, a patient presents with a dull, boring periocular pain and sometimes a mild visual loss. They have disc edema, macular edema, and choroidal folds, sometimes an exudative retinal detachment. Then hypotonic maculopathy, following surgery, especially the trabeculectomy, or it may be post-trauma. IOP can fall down to 4 or 5 millimeter, and the axoplasmic transport there is a stasis of axoplasmic transport resulting in disc edema and folds. Now, in all cases of disc edema, we need to do a detailed history and a thorough clinical examination. Often, we may have difficulty in distinguishing atypical optic neuritis from a non-arthritic AION. Here, relevant investigations help us to reach the diagnosis, and visual field testing in our OPD is a very important tool. Start the treatment early if possible, and in most cases, we can prevent the optic disc from going into a pallor. Thank you.
Thank you, ma'am, for that organized compilation of the causes of disc edema. Next, I invite Dr. Sindhu NM, Associate Professor, Government Medical College, Ernakulam, to introduce us to the mimickers in disc edema.
Good morning to all. What are the mimickers of disc edema? The disc edema is the swelling of the optic disc. It includes all the causes of active or passive edematous swelling of the optic disc other than the causes of papilledema. We can notice in a case of disc edema there is hyperemia of the disc with elevated margins, disc elevation, blurred margins, nerve fiber layer swelling and tortuosity of the vessels. Whenever you get a case with a disc edema, you should look for is it true disc edema or it's not. The causes of pseudo-disc edema or the mimickers of disc edema includes optic nerve head drusen, myelinated nerve fibers, morning glory syndrome, tilted disc, small hypermetropic disc, optic disc hypoplasia, and Buckminster's papillae. I'll go into each one in detail. Optic disc drusen is a highly like calcifical material deposited within the substance of optic nerve head. It is seen in 0.3% of the population. It's often bilateral, and some association include retinitis pigmentosa, angioid streak, Alagille syndrome, and complications are usually rare with optic disc drusen, but sometimes you can get CNV, central retinal vein occlusion or central retinal artery occlusion. Imaging, the fluorescent angiography shows progressive hyperfluorescence due to staining but absence of leakage. Ultrasound, most reliable method because of its ability to detect the calcific deposits that show high acoustic reflectivity. This is how the first picture shows. In fundus examination you can see the calcific depositions. This, in OCT you can see, OCT helps in delineating optic disc gluten. It is for fluorescent angiography, autofluorescence, and CT is not usually diagnostic due to the radiation, but you can coincidentally see bilateral optic disc drusens. Myelinated nerve fibers in normal eyes, optic nerve myelination stops at the cribriform plate. Ganglion cells retain a myelin sheath in this case. It's most often unilateral. The ocular associations include high myopia, anisometropia, and amblyopia. The systemic associations are neurofibromatosis 1 and Golin syndrome. This is a fundus picture. You can see in usual fundus examination, you can see myelinated nerve fibers are in the peripapillary area or in the posterior pole. In OCT, you can see a hyperreflective layer in them. Next is a morning glory syndrome. It's a very rare condition, usually unilateral and sporadic condition. Visual acuity may be normal. Fundus examination shows a large disc with funnel-shaped excavation surrounded by an annulus of chorioretinal disturbances. Blood vessels may emerge from the rim of the excavation in a radial pattern like the spokes of a wheel. This is a morning glory flower, and this is how the fundus shows a very large disc with excavation and vessels in a radial pattern. The systemic associations include frontonasal dysplasia, hypertelorism, flat nasal bridge, and occasionally a mild midline notch in the upper lip and a midline cleft in the soft palate. It will be associated with midline brain and malformations. It is absent corpus callosum, hypoplastic cerebellar vermis, small optic chiasm, malformed occipital lobe, and pituitary deficiency. NF2 is an association though it's less common. It can also associated with face syndrome. Tilted disc is another mimicker, common and usually seen bilaterally. It's caused by an oblique entry of the optic nerve into the globe. The signs include a small oval or D-shaped disc. The margins are indistinct where the retinal nerve fibers are elevated. The associations include inferonasal chorioretinal thinning, myopic astigmatic refractive error. In the perimetry, we can see a superotemporal defects that do not respect the vertical midline. This is how you see a congenital tilted disc on fundus examination. Other mimicry is optic nerve hypoplasia. It's unilateral or bilateral, characterized by diminished number of nerve fibers, commonly involving midline structures of the brain. The predisposing factors include some agents taken by the mother during the gestational period, or like LSD, quinine, anticonvulsant, or excess alcohol intake. Superior segmental hypoplasia may be associated with maternal diabetes. It's a fundus picture showing hypoplasia. You can presentation, bilateral cases present with blindness in the early infancy. Unilateral cases usually present with squinting. The signs, visual acuity may be normal or impaired to a variable degree, even to a no perception of light. Fundoscopy shows a double ring sign. The small gray disc surrounded by a yellow halo of hypopigmentation caused by concentric chorioretinal atrophy. The distance from the fovea to the temporal border of the optic disc often equals or exceeds 3 times of the disc diameter. Here, the retinal vessels are normal in caliber but tortuous. This is double ring sign, the yellow halo. The peripheral margin of the encircling ring corresponds to the border of the normal sized optic disc. Other features include astigmatism, field defects, dyschromatopsia, afferent pupillary defect and foveal hypoplasia, aniridia, microphthalmos, strabismus and nystagmus. The systemic association shows wide variety of midline developmental brain defects, most common Demystifying syndrome, characterized by absence of septum pellucidum, agenesis of corpus callosum or hypopituitarism. Bilateral optic nerve hypoplasia may be a marker of potential endocrine dysfunction. The last one is a Burgmeister's papillae. It is a remnant of the fetal hyaloid artery that can be seen on ophthalmoscopy or OCT. It is an asymptomatic and benign. Thank you all for it.
Thank you, Dr. Sindhu, for that concise description of the mimickers. Now, with the multiple provisional diagnosis, our mind is as blurred as the disc. And to clarify this, we have someone with a very strong academic and clinical background in neurophthal as well as medical retina. Introducing Dr. Natasha Radhakrishnan for her talk.
Thank you, Dr. Deepa, for this opportunity. Good morning to all. So we can now see how imaging modalities will help in clarifying a blurred disc. So we have already gone through the causes, so I'm not going into that. So an approach to a case of disc edema, we said history. So the symptoms of raised ICP, systemic symptoms, then assess visual function, ocular examination, and then we come to the ancillary testing, which is ocular imaging. So you can have a visual field that helps you, OCT of the disc and the macula, fundus autofluorescence, ultrasound, photography, and fluorescein angiogram or the ICG angiography. The most important thing that we need to distinguish in our clinic usually is to distinguish between pseudopapilledema and papilledema. So for that, you have to first look at the refractive error of the patient. Is the patient hypermetropic, which suggests that the disc is just small and crowded, or is it like a optic disc drusen? Why to differentiate? And how to differentiate, because why to differentiate is because you will send the patient on a wild goose chase to the neurologist and everywhere else, end up getting an LP and everything, when the patient actually had something that you could have ruled out in your OPD before you sent. So that is the importance of differentiating these conditions. And what are the things that give you the signs and symptoms, of course, then the refraction, then clinical other clinical hints, and like a lumpy bumpy appearance in the case of an optic disc drusen, which is not a uniform enlargement of the or rising of the optic disc. And the things that help us in this are the ultrasound, the fields, and the FFA. The fundus autofluorescence is a very important tool to distinguish optic disc drusen from pseudopapilledema. So the autofluorescence normally shows a dark optic disc because the absence of the RPE and lipofuscin. However, in optic disc drusen, there is fluorophores that are detected on the autofluorescence. So this is a disc that actually looks like a very early papilledema, and but on autofluorescence you can see the buried drusen on both sides. The B scan is another important investigation. It can help us in drusen, which Dr. Sindhu had shown, because it will have a hyperreflectivity there with like a extra shadowing. But another thing that it helps us in differentiating the drusen. Optic disc drusen. Another thing that it helps us in differentiating is the T sign that comes in posterior scleritis. Along with the disc edema, you would be able to see the T sign, and also you can see the elevated disc in the center. So both ways it helps us in differentiating. Now, when will you do a fluorescein? So, fluorescein angiogram helps you in looking at the blood flow at the disc. So, in cases of pseudopapilledema and papilledema, if you absolutely cannot differentiate that it looks blurred and all other sides, there's no hypermetropia, you're not able to figure out if it is papilledema or pseudopapilledema, then a fluorescein angiogram will help you, because even in early papilledema, you will get some leakage of the disc, which will not be there if it is a pseudopapilledema, if it is just a crowded disc appearance. So that is one way. And you may also pick up choroidal folds which are not seen clinically. In AION, fluorescein helps us because it will, in arteritic, you will get a significant increase in the arm retina time. The early phase sectoral filling defect can be very clearly seen, and late optic disc leakage will be seen. In arteritic, you will find severe choroidal filling defect also. So this is an arteritic AION where you can see that the choroidal filling is also very patchy. And this is a simple non-arteritic AION on the left side, and this is the optic nerve head showing the increased values in the RNFL, and this is the altitudinal field defect, and here you can see the filling defect, sorry, that should be inferior, superior filling defect here, and then the late leakage. The diabetic papillopathy, this is again an innocuous condition, it sort of signifies that the patient is progressing into PDR, but it really does not require any intervention. So here you will get prominent disc telangiectasias, and you can confuse it with NVD, and the differentiation, one differentiation from other causes is that the vision will not be affected. If the macula is not affected, there will be no decrease in vision. And how will you differentiate it from NVD is to look for global ischemia in the FFA. If it is just a diabetic papillopathy, there will be disc leakage, but the CNP areas will not be too much. If you get CNP areas, a lot of CNP areas along with disc leakage, even if you think that it is diabetic papillopathy, better to treat it as an NVD. So this is how the telangiectatic vessels look in a diabetic papillopathy. The LHON, you can get peripapillary telangiectasias with no leakage, no significant leakage on FFA. Optic disc granulomas, you can get a late phase hyperfluorescence. Inflammatory conditions, you will get diffuse optic. So you cannot differentiate papillitis from papilledema with a fluorescein angiogram. Both will leak just the same. AION also, if you do an FA and you don't concentrate on the initial phases, you may not be able to differentiate whether it is an optic neuritis or an AION. The initial sectoral filling defect has to be picked up if you want to differentiate that. And in pseudopapilledema, of course, none of these features will be seen. VKH, along with the disc leak, you can look for the pinpoint leakages that tell you that the choroid RP complex is now leaking. In OCT, how does it help? Will it help if you want to differentiate early papilledema from a crowded disc? No, because early papilledema also values will be lower part of the increased from normal, and in crowded disc also it will be in the lower part of the increased from normal, which means it will be white. But if you are in severe papilledema, and if you want to differentiate very elevated disc, then you will find that the values in papilledema compared to optic neuritis are far more than optic neuritis. Just like we say the disc edema is far more in papilledema, the measurement is also just the same. So the importance of an optic disc RNFL values come in monitoring more than diagnosis. So one is quantifying the disc edema in the beginning, and then as you can progression of the disc edema or going into optic atrophy, you can monitor using your optic disc RNFL. So in conclusion, imaging is an integral part of investigating a blurred disc. Used and interpreted alone and combined, they help us to reach a reasonable diagnosis. But it's important to know what and when to use and the findings in each condition if you want to differentiate the conditions. I have not gone into MRI, and I think that will be covered in the optic neuritis topic. I think we have some time left. If I will be going for the next session, so if anybody wants to ask any doubts, I'll be happy to answer.
Madam, to come to a conclusion is usually difficult. We have to send for imaging and all that. So is it always advisable to start IV steroids?
For optic neuritis?
No, disc edema, when whether it is optic neuritis, whether it is AION, there's a confusion.
No, absolutely not. Because you're doing the patient a disfavor if you're going to start steroid, systemic steroid, without reaching a conclusion whether it is AION or optic neuritis. Now, why do I say this? Because if you are if you're thinking it is AION, the patient's got AION because of hypertension and diabetes. Now, you're going to give him steroids, which is going to worsen his hypertension and diabetes and doesn't serve any purpose. Secondly, if it is an optic neuritis, you have no business giving systemic steroid in the oral form. It should be given IVMP. Patients in the ONTT who were treated with oral steroids had a worse visual outcome than patients who were treated with, not visual outcome, but the occurrence of MS in that group was much higher than the patients who were treated with IVMP. So both ways you're doing the patient a disfavor by starting systemic steroid. So how can you differentiate? All these things will help you differentiate. Now, if you absolutely cannot differentiate with this, then you go in for a VEP and an MRI. And the VEP will show prolonged latency in optic neuritis. In AION, only a decreased amplitude, no difference in latency. And in an MRI, you will find the demyelination plaques if it is an optic neuritis. So those ways also you can differentiate. So I would just observe and not start IVMP or systemic steroid.
Thank you, because there's always a tendency to start injection DEXA and all. That's why.
No.
Thank you, ma'am.
Correct.
That's the only emergency in which you want to give IVMP urgently because you want to save the other eye. Optic neuritis is not a die-hard illness. There is no harm in doing the MRI and confirming that there is no intraocular pathology. Because sometimes you can have infective conditions along with optic neuritis. It could be an infective condition which is producing optic neuritis. Then you need to take care of the infective condition also. So pushing in IV steroids is not the ideal thing without the exact diagnosis. So only if you strongly suspect an arthritic AION, which is an elderly patient who comes to you with very poor vision and may or may not have signs and symptoms of jaw claudication, but what you can do is you can do an ESR CRP platelets in your OPD, get that done, and if you clinically feel the temporal artery is not palpable or pulsations are very feeble, and get a physician's opinion about whether the patient is fit to get an IVMP. And that's the only time you're doing a favor to the patient by preventing the next eye getting the attack. You cannot save that eye because that eye is already gone. It's a pallid disc edema. That's the only true medical emergency. I agree with Natasha that you don't have to immediately start IV steroids in optic neuritis, because optic neuritis, if you see the course, it reaches a plateau and then it improves. That's the normal, typical optic neuritis. So, but you have some time. You get the proper investigations done and then only start. And in AION, the studies have shown that steroids do not really help in the final outcome. You are actually going to do more harm. I had one patient whom I didn't start treatment because it was AION. Patient went to a neurologist. He started the patient on IVMP because neurologists always think in terms of optic neuritis. Patient developed a myocardial infarction. And because his everything shot up, he developed a myocardial infarction. He had to undergo angioplasty, so many things, which was totally avoidable if you can make that.
Yeah, I have had the same experience. IVMP given by the neurologist, and the patient admitted with, he had a COPD that worsened, and then he was admitted in the ICU. And they came back and said, "Madam, vititanu idellam sambhavichadu."
So how long can we wait before for that? Supposing the investigation takes a long time, maybe 1 week, is it okay that we wait till we get the reports?
1 week should be okay, because it does reach it will increase for some time and then it will plateau out. So depends on when the patient reached you. And after that, it's going to improve if it is a demyelinating optic neuritis. The other point is also very important, because your optic neuritis may not be demyelinating at all. It may be because of pansinusitis, or it may be because of some other infiltrative thing inside the orbit. So that also needs to come out before you push in your IVMP.
And the only investigation I would definitely immediately do, apart from arthritic in an optic neuritis AION scenario, is MRI. Yeah. MRI is the only really thing. All other serology, everything can wait. Okay, MRI, you get it done. You should, even if you don't see plaques, it does not mean it's not optic neuritis. It could be an isolated optic neuritis. It need not be always demyelinating optic. In India, we don't see so much of MS. We see more of MOG and other. Even it could be infective condition producing an immune optic neuritis. So you don't see much on MRI, but optic neuritis is a clinical diagnosis. You go by your instincts, and then you do serology, but MRI is the most important investigation you have to do. You will get the results in 1 or 2 days, right? At least the next day you can call up the radiologist.
And if the patient comes late to you, presents late, maybe 1 month or 1.5 months, is there any role in giving IVMP then?
You
Once
look at the disc.
Yeah.
You look at the disc. If the patient has completely improved per se,
No. The vision is still
bad.
see-
So that's not a very typical optic neuritis. Like, then you have to think, but you will still do all the investigations. And if the patient is symptomatic, and if you're showing like you're getting a prolonged latency on VP, MRI may or may not be contributory. But patient is in that age group, young patient, you can give. We can do a flash VP.
Thank you, Dr. Natasha.
Thank you.
Now, we are going into the treatment modalities and outcomes. To speak on this, we have the head of the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at Giridhar Eye Institute, Dr. Neena R. With her vast experience in the same, she'll be enlightening us on the treatment options.
Thank you, Deepa, for this opportunity. And it's a very vast topic, so I cannot do justice to it in 10 minutes. So I'll just touch upon some case scenarios we've had and hoping that you will get some cues about the treatment. So there is no one treatment for all. It's no one tailor-made treatment. You have to go by your clinical diagnosis, investigations, and other serological tests. So this was a 21-year-old male who came to us with complaints of transient vision obscuration since 2 weeks. The visual acuity was good, 6.6 and 6 pupils were normal, anterior segment within normal limits. So catches transient visual obscuration since 2 weeks. Okay, so this is the fundus. What does it look like? Definitely bilateral disc edema, disc changes with vascular changes bilaterally, hard exudates, looks like papilledema, right? Yes, looks like established papilledema. Okay, so we went ahead and did the fields. Now, fields were not exactly very good. You can see there is a enlarged blind spot, but there is also central involvement. But of course, this was not very reliable because low test reliability was there. So we did an OCT. OCT, what does it tell you? OCT can show these retinal nerve fiber elevations. That's all in the initial stage. But the GCL told us that this was going on for some time. There was some GCL thinning. It's all in red. So yes, so this was a long-standing disc edema which was beginning to give, probably producing axonal degeneration. And if you don't treat it, it's going to produce optic atrophy sooner or later, even though the vision was good. So what did we do? We did an MRI. And yes, when you have a patient like this, what do? You do an MRI. Ideally, you should do an MRI brain with MR venogram. Okay, that is the investigation of choice in papilledema, because you want to rule out a space-occupying lesion, you want to rule out a condition known as cerebral venous sinus thrombosis, which can also present like papilledema, and you want to rule out the more common idiopathic intracranial hypertension. So our clinical diagnosis is papilledema, which is confirmed, but there is an intraventricular central neurocytoma, which is producing obstructive hydrocephalus in this patient and raised ICT. So it is fitting into this. So this is a tumor which is arising from the choroidal plexus. It's a very slow tumor. It grows, compresses, and when the patient has developed an obstructive hydrocephalus, he has come to us. So it's an urgent condition, and we referred the patient to the neurosurgeon. Before the tumor surgery, you have to reduce the ICT. So they did a shunt. First the shunt for the obstructive hydrocephalus, then only the tumor surgery. So patient did well, but did have some GCL thinning because this was going on for some time. So it's not like that papilledema cannot produce visual acuity problems. If you don't treat it, it can. So this is a second patient. Came with headache, a 27-year-old young lady. She has had tinnitus for some time and she was going to ENT doctors for a long time. She was obese and clearly she has said she had a weight gain of more than 10 kgs over the last 1 year and her BMI was 30.1.
Pupils were normal, color vision was full, anterior segment was within normal limits. So this is the optos picture. I'm sorry, I don't have the CP, but I think you can still make out that there are fuzzy disc margins. And this was looking like papilledema again. So yeah, good vision, young lady, what is your diagnosis? We will think definitely about idiopathic intracranial hypertension. Yes, that's what I also thought. And yes, the visual fields were showing some central scotoma, but she did not complain of any defective vision, but her foveal thresholds were low here. You can see 27, 25. Now, OCT RNFL is helping you because its RNFL elevation is documented. GCL is good here. Look at the GCL. So GCL also, you please look when you look at the OCT. If you have an elevated RNL but good GCL, you can be sure there is no axonal degeneration yet. It's just a passive edema. So, yes, so we wanted to rule out SOL, CVST and IH. So we did the MRI. MRI was essentially normal, but these were soft signs for IH were there, like tortuous optic nerves, perioptic, subarachnoid, prominent spaces, partial empty cella. So MRI does give you some soft signs which are typical of IH, normal venogram. So this is probably IH. You can't treat her yet. You need to send the patient to the neurologist to get a CSF opening pressure with lumbar puncture. So she did undergo a lumbar puncture. CSF opening pressure was 30. So she was initiated on oral Diamox 3 times daily, along with weight reduction, which is very important. Even a 10% weight reduction can improve your symptoms and signs dramatically. So that's something we overlook, and that's something we need to give stress and tell the patient. So this is, you can see, you can follow up these patients with OCT. That's what I want to tell you. You can avoid serial lumbar punctures by doing serial OCT. So you can see the serial reduction in RNFL edema over 8 months. But you look at the GCL, it is preserved, which means she is not going into optic atrophy because you are reducing the disc edema, the raised ICT with the treatment. The RNFL is coming down, but GCL is preserved. And her visual fields improved with time. Patient 3 is a 37-year-old male nurse who was working in UK. He came with complaints of sudden decrease in vision in the left eye followed by the right eye. He had a history of URI with fever about 2 weeks back. Visual acuity was poor, counting fingers in both eyes. Pupils were sluggish. The left eye had an RAPD. Color vision could not be comprehended because of the poor vision. And if you see the fundus, what do you see? The right eye disc looks okay. The left eye, it is hyperemic. There is some edema, right? So in this case, an OCT will help you. Look at the OCT. The left eye, it is definitely showing an RNFL edema, right? It is showing. The left eye, it is probably borderline. And when you look at the GCL, it is borderline. It's usually you get about 50s in young patients. It's about 40s. So is this papilledema or a symmetrical papilledema or optic neuritis? But there was RAPD. Patient's vision is poor. So I would err in the diagnosis of a bilateral asymmetric optic neuritis here. So we did a VP. What did VP? Waveforms are very poor even in flash VP, but what you can see is that, the left eye, the latency is much high, 162 compared to the 114. So 125 is your maximum, that is you have it on flash VP. So latency is prolonged. Left eye had RAPD also. So I am thinking about bilateral optic neuritis here, and it was. So the MRI brain with orbits showed intracorneal optic neuritis in both eyes. He was sent for a serology, but we didn't wait for the serology. We gave him IVMP 1 gram for 3 days. In fact, we actually give for 5 days now, and then followed by oral steroids. He was also sent for serology. He came out positive for anti-MOG antibody, and NMO was negative. So this is a MOG optic neuritis. He was referred for LP. Subsequently, all investigations were done. CSF-OCP was absent. So a MOG optic neuritis diagnosis was confirmed. Slowly, the steroids were tapered off, and currently, the patient is on rituximab. So it's very important to do the serology in optic neuritis to distinguish whether it is a demyelinating optic neuritis due to MS or it is due to MOG or NMO, because the treatment is totally different. In MS, you give immunomodulatory therapy. In MOG and NMO, you give more of immunosuppressive therapy. So that is the difference. So at you can see the VP is improved eventually. The visual acuity improved to 6.6 N6 eventually, and his disc edema resolved. Okay, patient 4 came with complaints of scotoma in the right temporal side since 1 week. So this patient was about 60 years old, diabetic, controlled, hypothyroid, normal TFT. So you can see there was right RAPD, visual acuity, the color vision was also less in that eye, left eye was okay. So this is a right eye, what is this? Diabetic middle-aged patient. This is looking like an AION, right? Non-arthritic AION. So we did a visual fields and yes, he had an altitudinal field defect. So this is the typical NAION. And so we decided to do an MRI just to rule out other things and to be sure of our diagnosis. He was told to control his systemic risk factors and to evaluate for other conditions which could have precipitated this, and a close follow-up was advised. We didn't start him on oral steroids. Patient 5 is an obese young girl. She had a history of typhoid about 2 weeks back and she was put on IV antibiotics. She was studying in Chandigarh and there she was treated with antibiotics. She came to us because there was a blurred vision. I think it's 10 minutes, right? Yeah, blurred vision after the second day of typhoid attack, and she has been giving some history of transient visual obscurations prior to this also. So she was obese, so I had this thing in my mind. Visual acuity, right eye was 6.6 N6, left eye was 6.24 N8. So she had a left RAPD. Color vision, however, was kind of okay in both eyes. Anterior segment was within normal limits, though it was little slow in the left eye. So this is her fundus picture. Anybody can go for it. So this is definitely severe disc edema with hemorrhages, and exudates also are there. And there is what you see here, almost like there's a subhyaloid kind of a hemorrhage in the macula. So is this an established bilateral papilledema, or is it some neuroretinitis secondary to typhoid? Was our diagnostic dilemma. So we did some ancillary investigations like VEP, and you can see that the waves were very poor, especially in the left eye. Both eyes latency was prolonged, and you could see she had tubular fields, which was more in the left eye. So I was thinking this is definitely optic nerve involvement is there. I need to treat her. This is not papilledema. At least this is not definitely. And she underwent a lumbar puncture. CSF opening pressure was normal, and so we initiated her on IVMP 1 gram for 3 days, followed by oral steroids, because my diagnosis at this time was a post-typhoid optic neuritis, because post-infective conditions can involve bilateral optic nerves and produce a papillitis kind of picture. But here she had more like a neuroretinitis kind of picture. So we followed her up. After 6 months, her visual acuity improved to 6.9 N6. Color vision improved. It was always better, but it improved. The briskness of the response improved. And you can see the fields were opening up, and she still has a little bit of visual acuity problem in the left eye. So patient 6 is a 52-year-old lady who came to us with sudden blurry vision of the left eye of 1 day's duration. And this is her left eye, she is 6.12 N6, and this is Opto's picture. I think you can see there is incomplete macular star in the left eye. So this is a typical neuroretinitis. So in neuroretinitis, you don't have to give them IVMP. You can actually put them on oral steroids unless it's bilateral and it's very severe. So that's what we did. We did all the tests, and toxoplasma. You need to rule out infective conditions. TB and toxo are the two important things that we rule out before we start the patient on steroids. So she was positive for toxo IgG. And so the consensus now is no need to start anti-toxo treatment. If you want, you can initiate them on any antibiotics. But the consensus now is if it's only IgG, you can straight away start oral steroids. Now, patient, this is the last patient. He was a 42-year-old gentleman. This is one more patient. This patient was a lady who came with severe headache to her OPD. She couldn't sit or stand. Such bad was her headache, and she had blurry vision. Hypertensive, but we checked the BP, it was normal. Visual acuity was subnormal, 636, 660. This is her anterior segment picture. She had shallow AC with immature cataracts. Intraocular pressures were high. Okay, so undilated, we just had a quick look. This looked hyperemic. I don't have the picture because she didn't want to be dilated. She was so unwell. So I was thinking, is she having some aneurysmal bleed or something? And immediately I sent her for MRI, and it came out normal. There was nothing. So that's when we decided to have a second look, and this is where OCT really helped us. What is this? She actually had, so it's a very important thing is you have to do a dilated fundus examination, see beyond the disc. So she has this condition in which you get multiple serous detachments, and what you see these RP undulations. She's not having any neurological conditions. She's having a VKH or a Vogt-Koyanagi-Haradas disease, because of which she's having multiple serous detachments, and these RP undulations are very characteristic of VKH. So she underwent IVMP for 3 days followed by oral steroids, and she's currently on azathioprine for her condition. So very important, please do not miss dilated fundus examination. So this patient, a 46-year-old male, came to us with black shade in front of the right eye. He said he had this for a long time. Now left eye is also having a black shade. So visual acuity was subnormal, 624, 636. Near vision was also bad in 36. Pupils were ill sustained in both eyes, but no RPD. Color vision was full. Anterior segment was normal. This is his fundus. So again, is it neuroretinitis or is it papilledema, advanced papilledema? A lot of exudation, right? So the first thing we did in this patient was to check his BP. And his BP was 190 by 110 because something told me that this is malignant hypertension. And we referred the patient to the physician. So it was going on for some time. So it had produced some damage to the GCL. You can see the GCL. I don't have the GCL, I'm sorry. GCL was getting thin. So systemic hypertension sometimes can present like this. If it's ignored, it can even produce, eventually optic atrophy. So the take-home message is case to case. You have to see your clinical evaluation is most important. Textbook descriptions do not always apply to all cases. And just in a nutshell, if you want to differentiate papilledema from optic neuropathy, bilaterality is more in favor of papilledema, but you can have asymmetrical involvement. Optic nerve function is mostly preserved in papilledema, but not in optic neuropathies. If you have bilateral optic disc edema, first thing again to rule out is there bilateral optic nerve involvement or not, if there is a problem in MRI or not, and if there is, treat accordingly. And in IIH, before you start treatment, always do a lumbar puncture and a CSF study. Thank you.
Thank you, madam. VEP is a very important tool in evaluating disc edema. Next, we have Dr. Maria Tino PG, Assistant Professor, Department of Ophthalmology, Government Medical College, Ernakulam, to explain about VEP to us.
Good morning. My topic of presentation is a role of VEP in disc edema. So what is VEP? So VEP is a visual evoked potential. So these are the electrical potential initiated by the visual stimuli that are recorded from the scalp overlying the visual cortex. So they are used primarily to measure the functional integrity of the visual pathway or quantifying the functional integrity of the visual pathway. So in the previous section, Madam said about what is the importance of doing MRI. So I am doing a simple comparison between the VEP and MRI. So VEP explains the functionality of the visual pathway, whereas MRI gives information about the structural and anatomical information of the disease. So it is lateralizing VEP, but not localizing, whereas MRI gives information about where the disease is the localizing property. So under the given circumstances, they may be complementary to each other. So we can divide the VP on different types based on the stimulating frequency, based on the types of stimuli. So based on the stimulating frequency, we can get a steady state VEP because here the stimulating frequency is high. So in which the next VEP starts before the previous response ends. So we will get just a sinusoidal waveforms. So it is not used routinely because the parameters we use is the amplitude and latency. So they get inferior information about the amplitude and latency. Whereas in transient VEP, if the stimulating frequency is less than 3 Hz, we get a discrete deflection. So we will get information about the amplitude and latency. So this is a commonly used one. Based on the types of stimulation, it can be flash VEP or pattern VEP. So a pattern VEP is again divided into onset, offset, pattern reversible, etc. In flash VEP, the importance is it should be used in those patients who cannot fixate, having poor cooperation, and having media opacities. The problem is it is a cruder response. there is intersubject and intrasubject variation is there, we get 3 negative and 3 positive waves. So you should use flash VEP in a patients having poor vision. Whereas in pattern VEP, the first type is the onset offset type. Here the checkerboard pattern is made to appear and disappear. The importance is it should be used in nystagmus patients, because pattern, if we are using pattern reversal VEP in nystagmus patient, it will exacerbate the nystagmus. So you should use it in nystagmus patients. And the waveforms we get is the C1, C2, C3. It is opposite that of flash and the reversal, because the first wave is a positive wave followed by negative wave, then again comes the positive wave. So the first C1 at 75 milliseconds, C2 at 125 and C3 at 150 milliseconds. Coming to the most reliable waveform, that is a pattern reversal VEP. We get mainly three waveforms. That is, the first is a definitive N1 negative waves which occurs near the 75 milliseconds from the visual cortex. Then comes a prominent positive P1 peak at 100 milliseconds from the dorsal extrastriate cortex of mid-occipital gyrus, and the N2, that is a negative wave, which is variable. It can range from 135 to 145 milliseconds. It's from several areas, including the parietal lobe. And the important parameters is the amplitude and latency. What is amplitude? It is a time between the start of stimulus and the main positive peak. It is measured in milliseconds. Whereas the amplitude is the peak of N95 to peak of P100 in microvolts. So there are many factors, including the physiological factors, affects the VEP waveforms. They include size of stimulus, sharpness, brightness, speed of pattern reversible, and the physiological factors like age. Because age, we can see the prolongation of VEP latency. Then sex, females have more amplitude. The eye being tested, right eye have more amplitude. And depth anesthesia you should use. If in children, you should give light anesthesia. Then pupil size, we should test in undilated pupil. The visual acuity is also important to select which type of visual stimulus or which type of VP you should use. And the problem is each study shows different values for VP, latency and the amplitude. So each lab is expected to demonstrate its own normative values which can be used as a parameter. So the P100, again, it is the most consistent, most reproducible and the least variable waveform in VEP. So coming to the clinical protocol, the interpretation of VEP it should be considered within the context of patient symptoms, patient's clinical examination, and all the tests mentioned in the previous section like OCT, RNF flow CT, GCA, MRA. So it should be considered within the context of all other symptoms, information available about the patient. So first you should correct the refractive error. You should done an undilated pupil. Use a pattern reversal VEP stimuli of 1 degree check size if the visual acuity is more than 6/60 and there is no nystagmus. So it's the best choice in cooperative patients with a better visual acuity. You should take at least 2 average VPs to verify the reproducibility, and the pattern reversal is twice per second, and we follow the 10-20 international system for placing the electrodes. So here I am doing a simple comparison between the VEP waveform in optic neuritis, anterior skim optic neuropathy and papilledema. In optic neuritis, there is P100 latency increases significantly, but the VEP amplitude can be decreased as the disease progresses, but the significant change is the increase in latency. And the later the disease resolution occurs, the latency were found to decrease significantly during the first year and less significantly during the second year, and the most marked changes occurring between the 3rd and the 6th months, possibly due to the remyelination and angioinal reorganization. So here in the picture, we can see the right eye, the P100 latency is around 105 millisecond, whereas in left eye, which is affected, have 145 milliseconds. So there is a difference of both eye 40 milliseconds. Coming to the anterior skim optic neuropathy, the definite change is a decrease in P100 amplitude. But there can occur a normal to mild prolongation of the latency also. So in the latency prolongation in anterior skim optic neuropathy is much less than those in optic neuritis. So in the first picture, the P100, we can see in the picture we can see there is definite decrease in the amplitude and there is only a slight prolongation of latency in the left eye. Papilledema. So in papilledema, the VP waveforms can be normal or it can be P100 latency can be prolonged. So the problem is in elevated ICP may affect the VEP waveforms through its effects on the intracerebral structures rather than on the optic nerve. So we can notice increased VP latency in the patients having hydrocephalus without papilledema having increased P100 latency. Maybe it's effects on optic radiations. And after surgery, shunt surgery, or even after lumbar puncture, we can see there is improvement in P100 latency. So in this first picture, in right eye and left eye, the P100 latency is around 127, 126. Whereas in the second picture that is done after lumbar puncture, it is around 109. So come to conclusion, you should interpretation of the VP should be done within the context of patient symptoms, patient's clinical examination, and other investigation modalities. Thank you.
Thank you, Dr. Tinu. I think our time has concluded. So we don't have any time left for discussion. Take home messages. There is no emergency in giving IV steroids. The only indication is in an arthritic AIOL, and the emergency investigation needed is an MRI. Thank you.